the range, and also to what extent is that being their answers there consistent with other sources of information.
I work where the referrals come from. I work inside a pain clinic, and so I'm there. We rent an office within the clinic, and basically 100% of my work is with pain practice. And so all of my patients, they've been seen for a physical. They've been seen. We stagger it. They're seen for a physical exam, and then the nurse practitioners, for better or worse, say, I'd like to give you medicine, but I really can't. We need to go through the process. So go see the psychologist, and he'll decide if you get medicine or not.
Yeah.
Thanks a lot.
In Johnson City,
Yeah.
Pain Associates, for example, has a psychologist that's on board that's paid staff there. In my case, we receive consultations. We receive consults from physicians, nurse practitioners. The two largest are East Tennessee Brain and Spine and Wellmont Pain are the two largest groups. Then there's another group, Associated Pain, and Dr. Doulabon and some other individuals send. But those, East Tennessee Brain and Spine and Wellmont Pain are clearly the largest referrals.
And I would think, chronic pain is a huge issue. There are tons of patients like that. The comorbidity with all kinds of depression, anxiety, personality disorder. I heard one psychiatrist say, 80% of all pain patients have a personality disorder. I don't know that it's 80%, but it's pretty high, 20, 30, 40%. And certainly tons of them are depressed. And so you all are, as psychiatrists, are going to get into the pain world, I would hope, and be asked for consults, advice, should we do this, and should we do Cymbalta or not Cymbalta, or, there should be a lot of going back and forth between pain and psychiatry and treatment outcomes and what do we do with this person, so hopefully it'll be a part of your practice, whether you're prescribing opioids or not.
There was a physician, Dr. Valley, Mark Valley, who worked with Cersei Pain, and which is by where Quillen Rehab Hospital is located now, or used to be. And I was already seeing individuals, and I was scheduling people out for 3 months that were referred. And that becomes a problem because obviously people in pain want to be handled quickly, and that has other issues. But he had just started this practice with Cersei, and he called and said, I have some referrals, and I asked how many. He said 600 consults. So we couldn't do that. But there's clearly been a need, and it's been active in terms of, and apparently been doing this for 7 years now. It seems to fulfill a need. Any other questions or comments? Yeah.
To what extent do you feel that we can differentiate opioid use disorder patients malingering for the pain versus patients with bona fide pain complaints that might be exaggerating their need for the.
Well, that's why the BHI-2 is, I think, more helpful than the brief risk questionnaire in terms of getting a better sense of some of the personality characteristics that relate to that. Now, you'll notice that there was one criticism said that malingering could be better assessed, but there are enough scales in terms of defensiveness. The symptom dependency scale in particular on the BHI-2 is a nice thing to look at. And of course, in the interview, I also want to get some sense of the person's general psychosocial assessment, get an idea of their legal history and that sort of thing. But in terms of this particular scale, the symptom dependency scale, and there's another one that relates to general stability and having a sense of fulfilling or not fulfilling life's goals. That's helpful in terms of some of those. There is an issue in terms of, do I primarily identify as a pain patient? If I could snap my fingers, you never had any pain, what would happen? And how would you handle it? And so I think the BHI-2 at least gets at some of those questions.
And it goes back and forth. There's a number of people that have pain disorders, and people say, well, I can't figure out what it is. Your ANA is not positive or whatever, and we just don't know what it is. And so it's always unclear. Are they malingering? Do we not have the scans right to find it? And then you get the stories of later somebody did a scan or something and found it. And so that whole malingering thing, the staff told me they had one patient that got medicine and went out in the parking lot after his cane and threw his cane up in the air and twirled it. And I was like, okay, we probably missed that one. I think as we quit prescribing high-dose opioids, we get less of that because there's less reinforcement for trying to beat the system. And I'm legitimate, so I get a high dose. Well, if nobody's getting a high dose anymore, I think that's dropped off, and they'll just go to heroin, basically, or Suboxone clinic. But it's always tough to figure out.
Suboxone clinic has
Oh,
had
yeah,
some
we'll talk
controversy
Suboxone.
here recently.
Yeah. Suboxone clinics are going to be the next thing to try to rein in because there's all kinds of shapes and sizes, and we need to kind of get that down.
Ted, you should understand Mountain States Health Alliance wants to establish a clinic in Gray.
Oh, there's a ton of them.
So, yes.
Yeah. You got Steve Lloyd of the VA, I guess from Greenville, I think, is going to try to head a group to come up with guidelines about how, if you're going to run a buprenorphine clinic, what are you going to do? How does it look like? Shouldn't you have referrals and counseling and that kind of thing? Because apparently Suboxone is a terrible problem up here. East Tennessee is a huge problem for opioids, but apparently you all have got a unique Suboxone problem that we don't understand as much down in our area. But yeah, that'll be the next thing to wrestle with.
Any other comments or questions? Thank you. Appreciate your attendance this morning.